Good afternoon, everyone. Thank you so much for joining this SBRI Healthcare launch webinar on women's health. We're very excited to have you all here. We're just allowing one more minute for everybody to join us, and we're going to make a start. We've got quite a lot of participants, but I think we've got a bit of a tight timelines to make sure that you all have a chance to ask your questions. So I'm going to start off, but the beginning is all the stuff that everybody knows. We are here with the Small Business Research Initiative, the call on women's health. Really fantastic initiative. I'm really excited to tell you a little bit more about today. My name is Kasia Marsley. I am a Senior Program Manager at SBRI Healthcare. And if we move on to the next slide, please. So just to take you through the order of the day, after the introductions, my colleague Charmaine Mulligan will tell you about SBRI Healthcare, what the program is, and a little bit about the Competition 25, which is a phase 1 competition. And then we'll move on to the highlight of the day, Dr. Sam Fraser, who will give us an overview of the brief, women's health, and all the priority areas. Dr. Sam Fraser is a women's health lead at Health Innovation Kent, Surrey and Sussex, so an excellent person to give you an overview of the brief. And then we'll have some time for your questions, and we'll move on to the presentation from Alex Leach, who very kindly joined us to talk to you about the Health Innovation Network. Alex is a Deputy Director of Programs at Health Innovation West of England, but she'll be able to tell you about other regions as well. And then we'll move on to the presentation by another one of my colleagues, Mary Walker, who will talk you through the application and the assessment process. And we'll have another Q&A session, which hopefully you will make a good use of, and we'll close the day just before 3 o'clock. If we can move on to the next slide, please. So just a little bit of housekeeping. I can see some questions in the chat regarding the recording. So I'll start with one of the last points. We will indeed share the slides and the recording that we uploaded to the website, the SBRI Healthcare website, under the competition in the next few days. So yes, that'll be available to you. Thank you again for joining us and for your interest in this amazing call. Please use the Q&A box to ask your questions as we go along. We will answer some of them live, and some of them will be answered in writing. So please do keep an eye on the Q&A box as we go along. If you have if you're waiting for an answer for your question, it might appear in writing in there if we don't address it live. Please let us know about any technical issues in the chat, and my colleague Noelle will attempt to help you solve those. And just to let you know, I have a number of colleagues working, supporting in the background. We've got Noelle, who will help with the technical difficulties. We've got Tommy sharing slides. We've got Laura, Francesca, and Danilo, who will be helping answer your questions in the Q&A box. So thank you all for supporting. If we go to the next slide, please. I will now pass on to Charmaine.
Thanks, Kasia. Hi, everybody. I'm Charmaine Mulligan. I'm a Senior Program Manager at SBRI Healthcare. And today I'm going to take you through an overview of SBRI Healthcare and where this Women's Health Funding Call fits within the programme. So next slide, please. So for those of you who are not familiar with the programme, SBRI stands for Small Business Research Initiative. SBRI Healthcare provides funding and support to early stage projects to enable feasibility testing and technology development, as well as to more mature innovation by supporting implementation and real-world evidence generation. The programme is funded by the Accelerated Access Collaborative, which is a partnership of several organisations that work together to streamline the adoption of new innovations into healthcare. And it includes, amongst others, the Health Innovation Network and NHS England. And the focus of the projects that we fund are set by the priorities of NHS England and support the NHS long-term plan. So through the funding and support from our networks, the programme's overall aim is to improve patient care and patient outcomes. And this can be achieved through making healthcare more efficient, bringing new innovations into the care pathway, and making sure that the organisations that deliver healthcare continue to sustain and contribute to the UK economy. And next slide, please. So this is not an exhaustive view of the healthcare funding landscape, but it highlights at what stages of the innovation journey SBRI Healthcare offers funding, which, as you can see here, is from the point of translation all the way through to adoption. Today, we're talking about phase 1 funding, which is early in the innovation development journey, and it focuses on feasibility, scoping, and translational development. Next slide, please. SBRI Healthcare is aimed at SMEs and offers them 100% funding to accelerate innovations. The phased approach enables the phased approach to funding enables the programme to be a risk-oriented programme, and we aim to provide a straightforward application process and quick turnaround. And finally, we are supported by the Health Innovation Network, and you'll hear more about them later. And so can I have the next slide, please? SBRI Healthcare runs themed competitions that focus on specific healthcare challenges. And as I mentioned earlier, these themes are determined by the priorities of the NHS. We are particularly suited to SMEs, although other organisations can apply, but there does need to be a clear route to market identified. Organisations can be anywhere in the EU, but a tangible benefit to healthcare in the UK must be demonstrated through the project. At this early stage, the programme offers a phased approach to funding. So starting with phase 1, and that's what we're talking about today. Here, projects are for 6 months with up to £100,000 funding. And this is to scope and test feasibility. Then, subject to the funding being available, the phase 1 projects would then be eligible to apply for phase 2, which is a 12-month timeline and up to £800,000 in budget. And this would be to do testing and further product development work. All projects must start with phase 1, so you cannot apply directly to phase 2 without having done phase 1. And subject to the funding being available, then phase 1 and phase 2 are designed to run sequentially. So as you come to the end of your phase 1 project, you are getting ready to apply for phase 2. Next slide, please. So generally speaking, SBRI Healthcare is technology agnostic, and there are not types of technology that aren't eligible. That being said, drugs and therapeutics tend not to be suitable for SBRI Healthcare just due to the short timeframes of the project. So you can see here that there are many innovation types that we have in our portfolio, including devices, digital solutions, and behaviour interventions, to name just a few. There isn't a specific stage of development that innovations need to be at to be able to apply for phase 1. However, bear in mind it is a competitive process, so the more that you can evidence that your innovation, that there's a strong need, that there's some viability, then the more competitive your bid will be for funding. Next slide, please. So there are several possible outcomes you might see from your projects, both at phase 1 and phase 2. And not necessarily all the ones that are listed here, as it depends on what's relevant for your product and its development. But you can see that the outcomes from phase 1 include developing plans and strategies for different work streams for your innovation, along with identifying collaborators and partners. Whereas outcomes from phase 2 might include a minimum viable product, some clinical testing, much stronger engagement with patients and public, and much more thought about how your innovation aligns with NHS priorities such as net zero and health inequalities. So you can see there's a clear evolution from what you might produce in phase 1 and then what you might produce in phase 2. Next slide, please. So since the programme was created, SBRI Healthcare has supported well over 300 innovations and invested over £150 million. And if you go to our website, you can see more details about these innovations and a selection of case studies of the projects that have gone through our programme. Next slide, please. And so this gives you an overview of the organisations that we have funded that are in our portfolio. You can see that our portfolio is arranged by themes. So this can be settings, clinical area, or a key NHS challenge. And as you can see in the portfolio, its majority of it is made up with SMEs, but there are some universities or NH trusts or charities in the portfolio also. Next slide, please. So this is a snapshot of the impact that our portfolio has generated so far. There are many different types of impact that our portfolio has led to. A few I'd like to highlight. So one is now that there are over 100 companies within our portfolio that are realising commercial revenues. I just mentioned that we've made an investment of over £150 million. And you can see here that this has actually led to over 700 million being raised in private investment. And there are a lot of other economic impacts on here, but I think the one that's the most important is the number of people that have been reached, either through collaborations, through clinical trials, or most importantly, as the beneficiaries of innovations that have ended up in the healthcare system. Next slide, please. So on top of the NHS and the Health Innovation Network, we have a growing number of collaborators and partners that help us provide support to innovators throughout their journey. Some are focused on a specific health need and others for more specialist expertise. And you can see at the bottom of the slide, there are many of them there. We provide support to innovators throughout their journey. So at pre-competition stage, which is the stage we're at now, we organise webinars such as this one, drop-in sessions, etc., to engage with innovators to help with the application process. Once awarded, applicants have access to a number of workshops. We call this in-competition support. It varies with the needs of the portfolio, but you can see on here some of the things we've done in the past are things like workshops on PPIE, commercialisation, value propositions, alongside using the NICE meta tool to map their innovation. And then support also continues after your project is finished. We have what we call our in-portfolio support. Again, this varies, but it can include things like networking or showcase events, as well as webinars on very specific topics like regulatory or roadmap to the NHS, all designed to help and block any barriers to adoption. We also record the impact of our projects through case studies, our annual survey, and our annual report. Next slide, please. So today's launch event is to let you know about the Women's Health Phase 1 competition. And there are 3 different challenge areas in the brief: gynecological conditions and hormonal health, mental health, and chronic conditions and long-term health. You'll find a number of documents on the website, and in particular, the challenge brief has more details on the scope of these challenges. So do read them carefully and see if your innovation meets the brief. And you're also going to hear a lot more about that from our next speaker. So this gives you a whistle-stop tour of SBRI Healthcare and puts into context where this Women's Health Phase 1 funding competition sits within the overall programme. And I'll now hand you back to Kasia, who will introduce our next speaker.
Thank you so much, Charmaine. I just wanted to ask you all to please submit the questions using the Q&A box rather than the chat. It's just a little bit easier for us to monitor them and make sure that we can answer to you appropriately, either live or in the chat in writing. And I also noticed that a couple of people have their hands raised. I think, unfortunately, this format of the meeting doesn't allow us to unmute you and let you speak. So really sorry about that. But if you have anything to flag, please feel free to use the chat, the Q&A box as well. And then we'll read it out. I think there might be some requests for connections. So please feel free to use the Q&A box. And also, if you want to use the chat to share any contact details, feel free to do that. And then everybody can see the chat and the contact details in the chat. But if you want us to flag anything and say it out loud, then please use the Q&A box. Thank you very much. And without further ado, I'll hand over to Dr. Samantha Fraser to tell us a bit more about the brief itself. Over to you, Sam.
Thank you. So, yep, my name's Sam Fraser. I am the Women's Health Lead for the Health Innovation KSS. I also work for the National Institute of Health Research as Implementation Lead for the Primary and Community Health Services theme, where a lot of this women's work will be cited. I suppose the other thing to add is that I am female, so I'm a user of women's services, but I'm also a deliverer of women's services in that I am also a consultant clinical psychologist. So I think I've got a reasonably good kind of 360 view of the context in which this call is coming out. The last thing I would mention is that I've been supporting Sussex, one of our local integrated care boards, to develop their own bespoke response to the National Women's Health Strategy. And a lot of that work involved talking to clinicians, to women, and to commissioners about kind of some of the needs and challenges that women were facing in accessing accessing healthcare and consequently improving outcomes and impact. So next slide, please. So just to put things into context and set the scene a bit, I suppose, it's worth remembering that 51% of the population are female, and yet there are glaring health inequalities that exist between the genders. Life expectancy on the whole is going up for the population, yet for women that's falling. It's also worth noting that women live longer in poor health as well. So whereas men's kind of health remains relatively stable, women are actually kind of experiencing poorer health across the board. Women also have the additional issues of kind of gender-based violence and poverty, as well as kind of some of the impacts and legacies that we've had of the cost of living crisis and COVID. And then on top of that, women also hold a lot of the societal reins, if you like, in terms of kind of keeping families together, maybe sort of care responsibilities, and have a really big part to play in the sort of socioeconomic factors that increase our productivity as a nation. So across the board, it's really paramount that we optimize and A, we notice that women are experiencing health inequality, but B, that we do something about it. Next slide, please. So with that in mind, a very large survey was conducted back in 2022, where the Department of Health and Social Care went out to the general population and got over 100,000 responses back. They also went back to clinicians and institutes and clinical experts to really kind of start looking at, what are people's experiences of healthcare? How easily are they being able to access it? What are the outcomes looking like? Who's accessing services, and more importantly, who isn't? And from that survey, there were some key priority areas that kind of fell out of the report, and you can see those sort of listed down the side. Right at the top, unsurprisingly, is gynecological problems, but then also fertility and pregnancy, menopause, menstrual health, mental health, research, cancers and violence against women and girls. So as a consequence of these priority areas kind of being, I suppose, thematically kind of grouped, the government then went on to write a position paper, a policy, if you like, so the Women's Health Strategy. So next slide, please. So the Women's Health Strategy for England, there is one for Wales and Scotland as well, but I'll just refer to the one for England, also looks at kind of the core 20+5 existing health inequalities frameworks that exist, and try to think about some kind of key areas that we need to look at to support transformational change for women's health. And the key areas that were kind of came out of that were really first and foremost that women's voices needed to be heard. And with that, we mean tackling those taboos, those stigmas, really thinking how we listen to women, or how women perceived being listened to ensuring as well that women are represented across all spheres of the health and social care system as well. So not just as being kind of receivers of healthcare, but also kind of people who are responsible for how it can be created and delivered. We wanted to also think as well as another point and how we improve access, thinking particularly about not just kind of gynecological problems and women's problems, you like, but more broadly how women present to services often quite differently to men. What we found out that was a lot of information out there is very much through a male lens. So actually, we see a lot of experiences of diagnostic overshadowing for women's health, where women's pain might be dismissed, where their symptoms are not noticed because they're presenting in the non-traditional kind of way. We also wanted to think about areas such as autism, where we know we've got some significant increases for young women in sort of non-diagnosis, and dementia as well. So really just thinking a bit about how we can improve access to services. Again, addressing disparities between women as well. So recognizing that, women can have very different experiences depending on their sexuality, where they live, their ethnicity, their age. And that shouldn't be affecting the treatment that people get. We should be giving treatment to as many women as we can from all kind of parts of life. So I think it's important to kind of think about that intersectionality as well. The other area that kind of came out as part of the 6-point plan was to also look at how we provide better education and training. And I think this is important for innovators in that a lot of women are asking for self-care innovations. How can I be better informed? Because often we're finding that where people are getting information from is varied. It may be from their their peers, but it may also be from places like TikTok, or it may be from more kind of evidence-based areas like NICE guidelines. But it's varied, and I think that was something that came through thick and fast. The other thing was that education for healthcare professionals as well needs to change. We need to be better at helping healthcare professionals to better understand what care is provided. How women are affected in the workplace was another area that needs to be thought about as well, and what considerations are we making in the workplace and in education for women. And finally, also thinking about innovation and research, noticing again that lots of innovation is shaped around male health, not specifically for female health. We are also noticing that a lot of research is not being done by women, for women, involving women. So there's a real kind of deficit there in terms of our discovery. So as part of this female health strategy, we wanted to, each ICB has been tasked with creating an implementation plan, so how they're going to take some of these key priorities forward. But also part of that will be developing something called women's health hubs. And these will be models of care that hopefully provide that holistic wraparound care for women. They may be at place, they may be mobile services, they may be kind of hub and spoke models, they might be digital models, but the important thing is they offer women a one-stop shop to resolve their healthcare problems, because we recognise that we can't separate out women into gynecological problems without thinking about the mental health problems or domestic violence or some of the other areas that might impact on their care. And another big area I think we need to be focusing on as well is that opportunistic care as well. So if we've got a woman coming in to see us for a pessary fitting, are we doing risk stratification for cardiovascular disease, for example, or are we giving her sexual health screens? Or are we checking in on sort of, domestic violence? So real opportunities to think about how we think more creatively and holistically with this women's health strategy, and more importantly, address some of these kind of priority areas that came up. So next slide, please. So with that in mind, I suppose drilling down into a bit more detail into those kind of core 3 briefs that were outlined in this call. So gynecological conditions and hormonal health. I mean, gynecology has probably one of the longest wait lists in the country of 52 weeks. So I was talking to the CEO of the Royal College of Obs and Gynae last week, who said if you could solve one of my number 1 problems, it would be to how to get these wait lists down. So what we know is that women are waiting for a very long time, which is affecting their quality of life, and it's also impacting on their ability to be able to function, and often they are in significant pain as well. So how do we help women to live to wait well? How do we get it right first time? How do we make sure that you create seamless kind of services for women? And there are some areas of improvement that have been kind of highlighted there about things like endometriosis, heavy periods. I spoke to quite a lot of young women as part of the Sussex Health Strategy creation, and it was really interesting to look at some of the misinformation that they had around menstrual health, but also more importantly, some of the information that boys were holding as well. And I think it's really important that when we think about education, we think about boys as well as girls, and how we upskill and educate everybody in terms of kind of, you know, what's normal and what's not normal. Next slide, please. So what might some innovation examples be? Well, we've talked about kind of that inclusive evidence-based kind of education approach, and again for the boys as well as girls, thinking about what kind of training needs to go into primary care in particular, particularly if we're thinking about women's health hubs being cited in primary care. What additional capacity or skills or technology or innovations can we put into primary care to support us getting it right first time, not putting women on these long wait lists for secondary care when they don't need to be seen in secondary care? How can women self-manage some of their difficulties and issues? Menopause would be a very good example of that. You know, what's a normal menopause symptom? I mean, it's interesting to kind of think, isn't it, about where we get our information from, and then again, kind of reducing some of those kind of screening and diagnostic times as well, so that we can kind of you know, prioritize and risk stratify better, and ultimately improve kind of gynecological care. Next slide, please. Oh, someone's just asked if you could switch the presentation view to make the full slide, as it's currently in next slide mode, which it is, to be fair. Sorry.
Tommy, could you just please either reshare or, yeah, sorry, I've only just realized as well that those were in the chat.
I thought I had my own special screen. A special screen.
I didn't want to interrupt your flow.
Oh, don't worry, it's fine. It's fine. It's fine.
Mm.
It's fine. I mean, yeah, I think there's, yeah, so absolutely kind of gynae is a really big #1 priority, and clearly affects, you know, will affect most women. So it's kind of it's a really important area to be thinking about.
Apologies, everyone.
That's okay.
Quite a lot of presentations. Sometimes it takes a little
I
bit of time to
know,
get
I
it
know.
going.
I can sing you a little song if you want me to.
Apologies if somebody else in the SBRI team would like to share. I'm having technical difficulties with my mic as well as my laptop, of course.
Okay, no worries. Noel, are you okay to share, please?
I'll share. Bear with me 1 second. Thank you very much.
Okay.
Thank you.
I might just mention as well, while we're kind of waiting for the slides, that actually what I think was also important and echoed through the women's health strategy was that we need to take a life course approach, and by that we are starting from effectively kind of menstruation. So we talk about young women through to kind of to older women, but how do we kind of think about the different physical health problems, mental health problems, socio sort of demographic problems that happen to women across the life course. So I think that's again something to be thinking about, and as we know, with the growing population, we need to be, and kind of increasing kind of complexity, we do need to be thinking more about sort of offset and prevention, rather than kind of thinking perhaps more upstream about treatment as well. I mean, I think it's really important that we think about how we can reduce some of that capacity that's flowing through our systems. And we talk a lot about integrated care boards, but I think it's important to think about integrated care systems, which include populations, which include voluntary sector organisations, which are very much part of helping us to solve some of those wider issues around prevention and upstream kind of support and help.
Just bear with us 1 second.
Okay.
Thank you so much. I think Zoom has refused to participate in this call. I think we were on the mental health slide.
Yes, you were.
Which
Yes, you were.
should be slide
Yep.
22.
Yep. Thank you. Brilliant.
Sorry, can you see that?
I can see it. Probably just need to put it into full in presenter mode would be great, and then I can. And everyone can probably see it without seeing the other ones distracting them down the side.
Right. Can you see that now?
Absolutely.
Yes, perfect.
Perfect. Right. Mental health. Area in which I obviously work, but came out as an absolute top priority. And I think the fundamental messaging again that came out was that women often described feeling unheard by healthcare professionals. And particularly again in terms of their feeling again dismissed, not being kind of appropriately kind of taken seriously, the areas around things like trauma-informed care as well. So sometimes, you know, women who were extremely traumatized having to tell their stories again, and thinking about that. Can we go back, please? I feel like we've jumped forward some slides. Sorry, thank you. So areas for improvement would obviously be around kind of increasing kind of mental health education, but also thinking again about intersectionality in women from different ethnic minority groups, women who are multiply disadvantaged, women from other kind of communities such as the LGBTQ+ community, women with neurodiversity. So are we making sure that our mental health services and provisions and innovations and research are fit for purpose for all women, so they are inclusive? Next slide, please. So again, some of the innovation examples that we've got here are thinking again, we've just mentioned being across the lifespan, but how do we create that kind of accessible, culturally sensitive information for women across the lifespan? How do we tailor them into a unique way for women? How do we think about things? Sorry, can we go back? Thank you. How do we think about addressing stigma and promoting kind of health literacy? Because there are many communities in which mental health or mental ill health is a very stigmatizing and taboo subject, which is not even kind of spoken about. So it's really thinking about how do we help women to access care when they need it, to recognizing as well some of those more vulnerable parts in a woman's life when they might be more prone to particular amount of mental health problems. So we think about perinatal mental health, for example, but we could also think about the higher instance we're seeing of suicide in the over 45s, and maybe is there a correlation there with menopause? So starting to think about some of the problems and difficulties that we're encountering. And again, recognizing that women and men will express mental health difficulties very differently. But how do we also upskill and support our workforce to recognize and to be able to be cognizant of their mental health too? And then finally thinking too about sexual violence and kind of trauma to women as well, and technologies that might help to support women to feel safe. Next slide, please. The other kind of area of part of this brief is looking at those more chronic conditions and long-term health conditions. And we talk there about health, you know, heart disease being the #1 killer of women. And again, I think there's a real need for us to be able to look at the different presentations that women have when we are thinking about kind of presenting with kind of heart problems. Some of those diagnostic tests that are still predominantly based on male samples. And I think we've seen this across the board, that it's very difficult to get women to participate in research for a whole plethora of reasons. But ultimately that means our information is skewed towards male presentations. And then finally, thinking about some of those kind of areas for improvement too. So some of education tools, self-management tools. Thanks. Next slide, please. So again, what are some of the innovation examples? Well, I've just mentioned there about looking at innovations that recognize differences, education tools that look at early diagnostics, and risk stratification, I think, becoming increasingly important. Again, how we look at people who are particularly at risk, personalized care plans, and also kind of recognizing that how we can kind of intervene as early as possible to support women to improve their quality of life and not deteriorate further. So I think there's a big work in the pre-frailty space, for example. So how can we optimize people's health? Next slide, please. Thank you. So I just wanted to pull some of these factors out that I suppose I came across really when I was doing some of the work with Sussex, to look at some of the kind of factors that affect women and some of their unmet needs. Oh, goodness me. Let's not press that button.
Oh, sorry, it's the automated slides,
Okay.
and we can't change it
all right,
now.
I'll
So
talk faster.
really sorry. We'll change it. We'll
Thank
change it
you.
before your next presentation.
That's okay. That's fine. That's fine. So just recognizing again that the different ways that women and men express mental and physical ill health, also the psychosocial factors and biology that affect women, some of those major transition events in women's health that will create additional physical stresses. So motherhood, menopause, pregnancy, lack of, loss, pregnancy loss as well. life experiences. We've talked a bit about, you know, violence, but also discrimination, unemployment, 0 hours contract, also have an impact on women's health. Some of the unequal kind of economic and social conditions impact on women's health, and their social realities. So things like lower income, less direct access sometimes to household resources, and the huge caring burden that women experience. And I think there's some statistics there from 2020 that there are nearly 90,000 people who are termed sandwich carers. That means they are caring for children as well as older relatives as well. So that creates a huge barrier for women to be able to access healthcare in timely ways. If you're trying to juggle work or you know, poorly paid work or insecure work, and you have caring responsibilities, it's a double barrier to being able to get support and help. So it's no surprise that some of the common mental health problems that women experience are depression, anxiety, and again, you know, issues around kind of isolation, and sort of poverty as well, and concerns about sort of even personal safety at home, which comes back to kind of sexual violence and physical violence too. Next slide, please. Again, this is just looking at that life course approach, so thinking about women in the context of those kind of 5 key kind of life stages, from childhood through to kind of older age. And I just put a picture there of something called the stages of psychosocial development, which I find quite interesting because it helps us to think from a sort of, I suppose, a psychological point of view of some of the factors that some of the transitions we're trying to go through as humans when we go through different phases of our lives. And actually, it's really important that we make those successful transitions so that we can then mature into kind of healthy adults. But we have to lay on top of that female biology as well, which means we've got added kind of factors to kind of think about when we consider women's health. And a good example of that would be if we look at women aged between 40 and 60 and we look at their psychosocial development, they're going through a phase of generativity versus stagnation. So they might be thinking about, you know, what was my position in the world? How did I contribute to the world? What's my purpose? So you can see that would be a really high risk time for mental health problems around identity, around kind of loss, grief, unresolved trauma. But it's also high, obviously, a really pivotal time for things like the menopause and all of the kind of the factors that fit with that. So drops in cortisone and dopamine and all those kind of, you know, kind of feel good kind of chemicals in our bodies that help us to kind of function better. And then also the risks, obviously, of heart disease and cancers. So there are physical health, mental health. So it's taking a biopsychosocial approach across the life course for women when we think about what might be helpful and useful for them. Next slide, please. Again, just being cognizant of inequalities, and we've got some stats there around how different kind of conditions affect and impact on people differently, in terms of kind of, there's an example there of autistic men and women being less likely to receive the appropriate help and to be sectioned. Similarly with fibroids, we know that it happens more prevalently in Black patients as well, and in fact menopause as well can often be earlier. So there are all these kind of things we need to consider and think about when we're looking at addressing inequalities, not just the male-female divide. Next slide, please. Finally, some of the barriers and enablers to women seeking support. We've mentioned shame and stigma. Women have talked about not feeling heard and dismissed. They often prefer to talk to non-professionals, but this can, of course, result in poor health literacy and acceptance and can mean that the messaging that women get might not be right. Real disparities between experiences as well. This can really be a place-based approach as well. There's a real, I think, at times unwarranted variation in terms of what women are experiencing depending on where they live. So a bit of a postcode lottery. And again, an inequality between physical health and mental health support means that we don't get that holistic wraparound care. Again, workplace support is poor at times for many women, and there's a real lack of understanding around female health per se. Menopause is a really good example of that. And again, a lack of data, and data is so important because it helps to drive our decision making, it helps to drive our commissioning, it helps us to really think about whether we're making a difference as well. But we still have a lack of segmentation around data, which is a real challenge. So what would help women? Well, making sure that they're heard. So I think from design to delivery to evaluation to really thinking about what do women do well and how can we enhance that. So the concept of social networks we know is much more advanced in women. Women will tend to reach out and confide and talk to their friends. So how do we optimize some of those strengths and resiliences? Recognizing that one size doesn't fit all. And again, talking about data, I think, but importance of education and information for boys, as well as for women and men. And again, more research to kind of make sure that we're building the evidence base as we go, so that we're not just doing something that isn't spreadable, isn't sustainable, but that can really kind of change outcomes for the greater good. Next slide, please. So just the key messages there, really: adopting a female-centric approach, co-design. Please, please, please involve women in every step of your development. It's really important to capture their voices, and I think, you know, reach out to those women who are more seldom heard, because you will hear very different narratives. And I think it's really important that we're not just doing for the few, but for the many. Acknowledging the differences that exist in gender, thinking about that life course approach, and as women go, how those will change. Being sensitive to diversity and intersectionality, making sure that we enable and empower women as much as we can. Adopting a trauma-informed approach to what we do, so not asking women to retell their stories over and over again, but to do things in a sensitive and empathic way, and instilling agency and self-determination as well. And obviously on the back of that is also that strength-based ethos as well around recovery. I think that might be the last slide on women's health. And then this is just a really quick whistle-stop tour about health equity. So I suppose on the back of what I've just been talking about, we at the Health Innovation KSS wanted to ensure that innovators were working in the most effective way, so that their innovations were not inadvertently driving further the kind of health inequalities gap. And by doing that, we need to ensure that we are delivering equitable healthcare. So with that in mind, we've come up with some kind of core principles and a bit of a toolkit framework that we are encouraging innovators to kind of use. Next slide, please. So what do we mean by health equity? Well, it's that realization that all people should have the highest level of health. And it's a matter of human rights and social justice, that everyone leads a healthy life, that disparities in health outcomes and health services and social determinants of health, such as education, income, living conditions, will affect disproportionately those people who are already marginalized and vulnerable. So again, if we think about the health inequalities gap, we have a potential of driving things further down. So health inequities also mean that we have a disproportionate allocation of resources to particular populations, and as a consequence, that just drives down further economic loss, which can lead obviously to you know, preventable illnesses, premature death, but also a lack of kind of productivity and possibility and hope. So it's really important that we think about how we address health inequality. Next slide, please. So addressing health inequity is not just a moral imperative, but it's also how we build healthy, resilient, equitable societies across the world. So in England, we think about marginalised communities and socially disadvantaged groups, again, having more chronic illness, such as diabetes, cardiovascular disease, and mental health disorders. And although the NHS is free at access, these groups do face additional barriers to accessing healthcare. And that can be through financial constraints, language barriers, discrimination by health staff. And that just perpetuates this poverty of ill health and just drives people further down into disadvantage. And it limits education possibilities too, and obviously employment possibilities. People in England's most deprived neighbourhoods work longer hours than the rest of those in the country, live shorter lives and more lives in ill health. And that is estimated to cost nearly £30 billion a year in lost productivity alone. So addressing health inequity is crucial if we want everybody, regardless of their background and circumstances, to live the best life that they can, to promote social justice and to enhance public health outcomes, strengthen social cohesion, and also create and strengthen our economy. Next slide, please. So as I mentioned, we at the Health Innovation KSS came up with some core principles. So there are 10 kind of core principles that we have brought out that we are encouraging innovators to look at their innovations and look at through these various different lenses. We can go on to the next slide, that's fine. So the next slide really shows in a little bit more detail how, if we were thinking about people, were we making sure that our innovation is kind of identifying the right stakeholders? Do we know who our vulnerable populations are? Do we know who's affected or not by our innovation? Can we address kind of those inequalities? And can we kind of think about what some of those root causes of inequity are? Or we could think about data as well. What are we measuring? Are we measuring the right information? How do we know we've got it right? Are we reaching the right people? So they're just some key questions that I think you can apply to your innovations to really think about, you know, I am cognizant of health inequity and I am thinking about how I will address this. We've also, I should say, developed a digital toolkit as well that helps to look at digital exclusion. So again, we just need to be really mindful that we're not driving health inequalities further by some of the new ways of working that we are introducing into the NHS and social care systems. Next slide, please. And then this finally is a slide really as to how you might want to use that health equity assessment impact tool. So it might help you to start a conversation in your organisation. Be open, be transparent. I think be your own kind of critical friend. You know, are you kind of aware of who those underserved are in your population and what are you going to do about it? How do you perhaps integrate people within those kind of conversations as well? How do you test and build partnerships and promote working around equity, making sure that you're involving people with lived experience throughout that whole co-production chain? And holding yourselves to account, I think, importantly as well. And then thinking about how perhaps you can impact on policy and advocacy. So what are you finding as a result of the work that you're doing? How might things change? How might this influence the next generation, if you like, of innovations? So again, just really being aware of kind of the work that we do, why we're doing it, and what we would like a good outcome to look like. So I think that's probably the end of what I was going to say. I think that's the last slide. I know it says questions, but I don't know whether we're going to put them in the box or we're going to do them later. So I might hand back to you, Kasia.
Perfect. Thank you so much, Sam. It was an excellent presentation, and thank you for persevering through the technical challenges, which I believe should be sorted now. But I think we can change the transitions on the slides to make it a little bit smoother. So Noel, feel free to stop sharing during the Q&A session, and the colleagues will help you if you need some help of how to change that. We've got a number of questions in the Q&A box, so I'll make a start of those, Sam, and if you can help me, that would be brilliant.
Yep.
Also perfect timing on the presentation, so thank you. The first question that we had was around the preventative tools, and whether preventative tools and aiming to get them to the market without the use of using the NHS is eligible for this call, and they provide a little bit more reasoning around not using NHS. They've learned that NHS and ICBs may be reluctant to invest in preventative tools since they cannot realize financial benefit to disease prevention within the same year as the investment. So the question is, what are your thoughts around preventative tools and engagement with NHS?
I think, yeah, I mean, I think I mentioned before, if we think about systems, so we think about an ICB as essentially an NHS organisation, so they're providing healthcare. Let's think about it as an as an ICS rather. So that's a system. So actually within that system, you then have public health, you have voluntary sector organisations, you have communities, you have individuals. So I think it's really important that we do start to think more about prevention and upstream. We need to reduce demand into the NHS. It's almost too late catching people kind of when they are unwell. So absolutely, we need to be thinking more about how we can work alongside public health initiatives, for example. So screenings would be a really good example. Breast screening. How do we kind of ensure that we are kind of thinking more sort of front end? I think the challenge is always that innovators or any new ways of working are always being asked to demonstrate an invest to save approach, which is a really quite difficult thing to do, given that we often don't know if things have saved us money until 5, 6, 7 years down the road. And in some cases, it may be a whole generation before we actually see a difference. So it's always going to be a challenge. I think it's working alongside your kind of commissioners, and I mean that in the broadest sense. So that may well be public health colleagues to look at kind of what they are, where are their kind of areas of concern. I can give an example. In Brighton and Hove, for example, we have one of the highest rates of stage 4 ovarian cancer being picked up. That means women are not being picked up through, they're not getting screened, they're not being picked up through regular screens. So, you know, that's kind of something that actually, if we had a better way of risk stratifying, of screening, we could have offset that. But that's not working necessarily with the healthcare system per se, that's working more upstream. So I think it's really important that we think about all partners. And I would encourage people to think, you know, where would my innovation sit best in a pathway? And how could that, you know, where would it give its biggest bang for its buck? Actually, so is it about saving bed days? Is it about actually, you know, saving, you know, offsetting people from getting to stage 4 kind of cancer? It's kind of really thinking, isn't it, where it works best? Not necessarily the easiest place, because I think sometimes we have a tendency to go for the easiest, the low-hanging fruit, when actually sometimes we need to be a little bit more brave. So I don't know if that's really answered the question, but
Yeah, I think it does. And I think, yeah, it really is, I guess, thinking about who you can engage, not necessarily with the aim to sell to them initially, but how can you engage them early on,
yeah,
being patients or support from NHS, but maybe, yeah, not with the kind of view of reaching the commissioning stage, but you know, how to really shape the innovation that it can work for the clinicians or before the patients reach clinicians.
exactly. Ultimately, if we look at those obs and gynae wait list, you know, they're the longest in the country. So there's a quick win. What can we do to tackle those wait lists? We need to get women off those wait lists, yes, but we need to think about how we can educate women to know what's normal, what's not, so they don't even have to go on them in the first place. So I think, you know, anything around risk stratification, getting, you know, making sure that we're helping women to wait well. So we might even find that by having a conversation with someone, we don't even need to be on a wait list. You know, it's really quite, sometimes it can be quite simple, I think, our approaches. I think it's worth just thinking a little bit more about how you view healthcare as well. So if we think about primary care as essentially residing in the individual, that's your responsibility. That's the self-management stuff. That's the behavioural intervention. Secondary care then becomes your community, your kind of your social networks. And then tertiary care is the health and social care system. And hopefully we keep people out of 3 and address problems in 1 and 2. So actually, what are we doing to offset and support
Thank
women?
you.
Yeah.
Thank you so much, Sam. So the next question is whether an innovation which cuts across more than one sub-challenge in the funding brief, for example, menstrual health and mental health, is it eligible if it cuts across 2 or 3? I don't know if that's possible with this one. But
well,
yeah.
I mean, I would ask the question: Are we disembodied heads, or just bodies? You know, we're not. We are people, aren't we? So actually, you know, by definition, you know, physical health problems have an impact on our mental health, and vice versa. And if we're living in chronic pain from a gynecological problem, and we're not able to socialize, we're not able to do our job, we're not able to kind of have, you know, have pleasure and meaning in our lives, it's very likely that we'd end up with a mental health problem. So it's kind of, you know, what precipitates what. Similarly, you know, you could have people with mental health problems who end up with long-term conditions. And we know that particularly happens in women with severe mental illness. So yes, I in my view, it would be remiss not to consider a holistic kind of approach if we can, because again, that will also, I think, have more bang for its buck as well.
Absolutely, yeah. And just to add to what Sam is saying is you can pick whichever category fits best. It's okay if it fits multiple. Just pick the one in the application form will just ask you to center on one, but you won't be at any disadvantage picking one over the other. Yeah, it's just for us to be able to triage the applications a little bit better. So we have a follow-on question as well. So there are 3 sub-challenges in the brief: gynecological conditions, and this question, I believe, is specifically about maintaining health, menstrual health, menopause, contraception, pelvic floor health. And this applicant is interested in applying for this sub-challenge. They want to do a feasibility study into developing an app for women from ethnic minority communities to access information and support relating to menstrual health, mental health, and well-being. Does it need to cover the full content of this point in the brief? Yes.
Okay, I mean, does it need to cover? I mean, I guess my argument, my question would be, go out to women and ask them. Ask them, would they like, one place to go for all this information? Particularly if you want to say that you want to look at a particular subset of women, you might. It's again, I think, can sometimes be quite challenging to segment things. You could argue, that good menstrual health kind of is also kind of, it's that across the lifespan, isn't it? So you might want to say, actually, I want to look at a tool or an application that supports women from particular ethnic minority groups across the lifespan, using their language, using their cultural references, working with some of their cultural leaders, thinking about what the knowledge base already is and adapting it, because, that probably, again, would be have more bang for its buck, I would think, than just looking at a really discrete area. But that's just my opinion.
Yeah, absolutely. I think if it's apparent in your application that the patient voices are the ones speaking the loudest and are heard the loudest, then it won't disadvantage your application. It doesn't have to cover the entirety of the brief or the entirety of the points. It just needs to make sense for the patient population you're working with, or the clinicians who are using your solution.
Yeah.
And I think we've got a few questions around eligibility of some innovations that were not specifically mentioned in the brief. So we do have one around breast cancer and whether breast cancer tests and whether it would be eligible. The question asks if it's considered gynecological health, but I suppose the real question is whether it fits in the brief and whether
It would fit under long-term conditions, I think, wouldn't it?
Yeah, I think it will. I think some of the considerations that are quite important are what some has been mentioning throughout her presentation is the inequality aspect and whether your solution, what was the unique selling point, and does it address health inequalities? Those are the most important things to consider. But yeah, we wouldn't necessarily deem it uneligible.
And I think it's ultimately about having a good justification, isn't it? It's a good justification for why you think this is important, having consulted with women, having consulted with clinicians. Just think, I think work together with your stakeholders to think about, what difference you're going to make. What's the impact going to be of the work that you do, and I think if you harness women's voices, it's actually very hard not to listen. And that has a very, very powerful sway, particularly with commissioners and people who ultimately will be funding some of the, some of these kind of innovations if they go on to sort of scale and spread. So I think it's really important to really, identify those populations you want to work with at an early stage and get them on board. And it's from that kind of, it's co-design, it's co-production, it's co-evaluation, it's all the way through. It's not just a bit of tokenistic talking to.
Thank you so much, Simon. We have another question around a different area that's also not specifically mentioned in the brief, and this one is around fertility and whether it can be counted as gynecological health. What's your view on that?
Yes, I think it's certainly been it was certainly one of the priority areas within within the sort of the national survey that came through. I think it's also recognizing that for many, I think there has been a bit of a sea change of people sometimes thinking that's a lifestyle choice when actually it's infertility is a medical problem. We know that not enough women are getting their kind of IVF allowance, for example. There's a real inequality across the country in terms of accessing kind of fertility treatment. So I think, fertility as well will go on to lead on to other problems around kind of grief, loss, all of those kind of, invasive kind of procedures women have to go through. So I think, I can't see why that wouldn't be, an area, and fundamentally it's going to be a gynecological problem that's probably causing it. So yes, I would think it would be.
Thank you. Yeah, and again, can't stress enough the inequalities that are present in this area as well. So I think especially those innovations that again address women who maybe have been forgotten in the past. Would be really keen to see those. We have quite a broad question but maybe we can
That's my mastermind.
what kind of behavior change interventions would be eligible? And before you start answering, Sam, I'd say that I do really encourage you to look at the challenge brief, which is available on our website. There's a number of those that are included in there. Behavior change interventions are eligible in the broad sense, but yeah, really look at the challenge brief, and there are some examples in there. Not to say that others are excluded, but I just wanted to ask Sam if there are any behavior change interventions that stand out to you as kind of key to mention right now.
I mean, I think there are certainly, I think, behavior change interventions that support kind of peer-to-peer work, actually. So actually, rather than thinking about how do we encourage someone to go to their GP to go and get an app to do some behavior change, actually, what could we be doing to support people in communities to be working, on, with kind of maybe community champions. And I know there have been quite a lot of really successful projects, certainly in sub-Saharan Africa, where they've kind of been training up community champions to work with behavioral management and behavioral change programs, because there isn't the workforce, and maybe that's something to think about more broadly. Actually, we don't have enough workforce in the NHS to deal with the demand. So behavior change is one way of thinking about how we can deliver healthcare to more people, or prevention to more people. What would be something I'd be thinking about? I think again, I'm not going to come at this probably from more of a mental health point of view, but neurodiversity is a huge problem for many of our healthcare providers at the moment. We know there are massive wait lists. So I think anything that can support helping people to stay well while they're waiting on wait lists, helping people to think about social skills, to kind of to basically not lose functioning. I think any waiting on a wait list, by definition, means people are kind of in sort of a holding position. So what can we be doing to help people maintain the degree of functioning that they already have, so they're not becoming increasingly distressed or increasingly in pain? So really thinking about how we can sort of hold people, and perhaps take them off wait lists as well, with kind of some of those behavioral management kind of tools. So that's probably where I'd be thinking more. It's kind of that waiting kind of area.
Thank you. That's great. That's really helpful. We have another question around the fit for two challenges: medtech devices increasing patient safety during childbirth and prevent long-term issues. Again, that's absolutely fine. Just pick the one that fits your innovation best. But of course, within the body of the application, you can explain that there's that it can potentially cover another part of the brief. We have a question around wellness practices and your recommendation, Sam, around what would you recommend for women, particularly those of childbearing age or approaching menopause, to maintain their overall health and alleviate symptoms associated with these life stages? A very broad one again,
Yeah.
but are you happy to give a recommendation?
What would I recommend? I mean, I think again, it's about optimizing, isn't it, the way that women want to receive information, that it's kind of consistent but all encompassing. So I know I was talking to someone the other day who developed a menopause app, and it's tracking kind of menopause symptoms, but they are menopause symptoms that are perhaps ones that we don't think about more readily. So they're not like things like night sweats, but they might be kind of anxiety or kind of sleeplessness. So just thinking a bit more about what are women experiencing, how can we make sure that they are kind of receiving all the information that they need to receive, how can they be working in more of a peer-to-peer kind of way as well. So yeah, I mean, I think it's kind of, yeah, there are lots of different possibilities and things that I think people can do.
Yeah, so talk to the users, talk to patients, include women in everything you do, and
look at that already out there as well. That's the other thing I would say. Don't reinvent the wheel, because I think you've got to have a bit of a USP when you're doing something here. So I think it's definitely worth looking on, you know, the sort of nice kind of guidelines, look at what's already out there, look at what other sort of, you know, what to Walker have kind of sort of signed off. Just have a real think about what's already there, and are you filling a gap
Mm.
or a challenge? I think that's the other thing, isn't it? We don't, you know, do we need more of the same? What are we missing? What are we not, who are we not addressing? And again, coming back to that kind of inequality piece, where are the women that we're not reaching? Because we know who we're reaching, we're not so sure about who we're not. And that's
Yeah.
about going out into your communities and talking to people.
That's a great point. Thank you for that. We have a question from an innovation which is perhaps slightly further on in their development. Are phasing categories determined by whether the product is implemented in the UK market, or only whether it is in the market for NHS? So this innovator has developed a product which has already been launched for private patients. However, they do not operate in the NHS yet, and they're looking to support, develop some evidence for adoption in the NHS. They're interested whether they would be eligible to apply for phase 1. Are we interested in some innovations that are a little bit further on in terms of their development, Sam?
I would think if they can demonstrate impact, and if they can, you know, with the cohorts that they've been working with, and I suppose the offer that they could make to NHS partners, bearing in mind there's a lack of funding, so that might be, you know, so if you know, getting the right pilots or test beds on board, then actually that might well be an opportunity to, you know, to think about using some of that private sector learning to apply to kind of public sector. So I think it's about, if you've got a good business model and a good way of telling the story of the differences that your product's making, then I can't see why you wouldn't be. But
yeah,
I guess
absolutely.
ultimately, you know, we all need to benefit from this. And I think what comes through thick and fast from all of this work is the need for us all to take a bit of a feminist approach, which is actually we need to collaborate, we need to work together, and the problems are not unique. And I think there's a real strength in numbers and a synergy in the work that we do. So let's capitalize on that rather than kind of working in silos.
Brilliant. Thank you so much. Absolutely. And just to let you all know, because I think there can be a little bit of confusion with the phases. This is a phase 1 call, so it's the earliest stage that we have, but we do see innovations at all sorts of different stages that come applying, and the entry point and exit points are there to give you a ballpark and to give you some ideas, but we understand that there might be dependent on your specific innovation, and we might see you at different stages of development. So that's absolutely fine. The phase 2 follows later on, and it's subject to budget and approvals from NHS England, as Charmaine mentioned earlier on. And phase 3 is a completely separate call. This is just for phase 1 at this stage, and there may or may not be additional phase 2 and phase 3 calls. It's all subject to sign off in the next few years. I'll just give you a final question, Sam, and then we'll move on to the next item on the agenda. There's a question around, it should be quite an easy one. So is it only technology or innovative devices, AI, that we're interested in, rather than transformation projects with women's health at the focus?
I mean, I think my view would be that I think we need to be all encompassing, really. I think we need to think as creatively as we can. We know that digital and AI excludes people, and we know there's still a huge kind of gender bias in some of that work. I think it's about ultimately, you know, strip it back to what you're trying to achieve, which is to improve experiences, improve access, improve outcomes, make a difference. And how you do that, I think is about working with your system partners to see about what they are kind of ready to adopt or think about. And I think, you know, given this is non-recurrent funding, it's important. I think we talked, didn't we, beforehand about the need to think about, you know, partnering perhaps with a you know, a business that enables you to have a business model which will keep, you know, will build in that sustainability. Because, you know, so I think it's probably partnering well to think ultimately about spread and think about adoption and think about that sustainability of what you're doing.
Yeah, we're open to all those types of innovations. So we're open to medical devices, in vitro diagnostics, digital health solutions,
Yep.
but also behavioral interventions and service improvements as well. So as long as it's inclusive and it doesn't impacts negatively workforce pressures, you can apply. And there's some examples in the challenge brief. So again, please go ahead and read those. So we'll conclude the Q&A session for now. We'll have another one later on, but I wanted to hand the floor over to Alex Leach, who'll tell us about Health Innovation Networks. Over to you, Alex.
Perfect. Hello, everybody. Thank you very much. Nice to meet you. Could I have my slides up, please?
Noelle, are you ready? Perfect.
Coming.
Just give us a sec. Yeah, I think we have the same issue with the
Shall we? I mean, my presentation is only 10 minutes long. If everybody's happy to bear with me. You obviously promised me not to read the next slide before I finish talking about the first one, but we'll see how we go.
Yeah, thank you.
Oh, we're trying again, are we?
I'm aware that you need to leave a bit earlier, Alex. So yes,
no problem.
let's persevere, and we'll share the slides
Yeah.
with all of you. They'll be available on our. Oh, perfect.
We
It
did
looks
it.
good.
Perfect.
Well done. Thank you.
Thank you so much. So I've got about 10 minutes with you guys, and really what I just wanted to do was talk a little bit about the Health Innovation Networks can help potential applicants. For those of you that are a little bit confused about who the Health Innovation Network is, some of you may know us by our previous name, which was the Academic Health Science Network. We changed our name back in October last year, ostentatiously the same organisations, but actually as part of our recommissioning from NHS England, we were given a new name, which actually I think is much more descriptive of our role. I'm from the West of England Health Innovation Network, but I'm very much here to talk about the network as a whole. But obviously, you know, some of the content I'll talk to may be from my own perspective, but I will try very much to sort of give a broad overview of what we can offer. Next slide. So very briefly, I'll talk a little bit about the role of the Health Innovation Network and how we function, a little bit about what we do and our offer to innovators, and then really how we can support you if you're keen to apply for this particular SBRI opportunity. Next slide. Next slide. So we're commissioned directly from NHS England, the Office of Life Sciences, and also Patient Safety Executive. And our ambition is to improve lives through innovation. I think it's been said in the past that we're the innovation arm of the NHS, but I think we do that in collaboration with SBRI, in collaboration with NIH, and other organisations that support innovation. We do that through improving the health of patients, but we also have an economic growth agenda. We're really, really keen to support UK-based companies and also companies that are keen to work and bring revenue and bring jobs into the UK, help them to grow. And ultimately, we're here also to save money for health and care by making sure that innovations that are adopted are really helping to improve outcomes, both for patients, but also for the health system as a whole. Next slide. So there are 15 health innovation networks across the country. We are only England-based. There are organisations that work with healthcare innovation in Wales, Scotland and Northern Ireland, and we're more than happy to connect you through to those if you feel it would be more helpful. We have a good website and we'll give you a link to that, and you'll be able to identify if you're looking to work out which health innovation is most local to you or most local to the hospitals or the systems that you want to work with. You know, the website's got a really nice tool that allows you to search for that. Over England, we employ approximately 700 people on the ground, and that's a combination of people who do project management, evaluation staff, clinical experts. So we've got a really strong resource that can support innovators and health systems to innovate in an as effective way as possible. Part of our work is to do with the adoption of national priorities that we can scale rapidly, but we're also really interested in supporting the development of an innovation pipeline that really drives the importation and exportation of really great new innovations. So we're keen, for instance, in the west of England, I'm looking at supporting my local innovators, those that are based on my footprint, to not only do well within my area, but also potentially to be used elsewhere. But I'm also really excited to learn about innovations that have been really successful elsewhere in the country that I can bring in to benefit my local region. We've been going for about 10 years, just over 10 years. So we're very, very expert at working with SBRI calls. We really understand about adoption spread of innovation. And we're very well placed to work across all the organisations that you might want to work with to make a challenge such as this successful. And part of that means working with obviously our NHS organisations, but we also have a lot of projects in social care with local authorities. We work closely with our universities and other academic partners. Aside from SBRI, we also work with the other funding bodies, investors, partnerships with industry and many more organisations, not forgetting things like third sector and social enterprises. Next slide. We like to think we're catalysts for change. Now, we don't have a buying power. We can't persuade a particular health system or an integrated care system to buy your product. But what we can help to do is help you to get the evidence and the arguments that put you in the best place to make your product as attractive as possible to our partners in health and care. We work locally, but we collaborate nationally. So you'll find us working very closely with our own regions, but we share and speak regularly, and we very much work as a network. Next slide. So locally, many of the Health Innovation Networks work as membership organisations where all of the universities, the hospitals, the integrated care systems have a membership model where we provide support on a two-way basis. So part of the deal is we will support them in their innovation agenda, but they will also support us when we have requests for support and advice regarding innovation adoption or questions from innovators. So it's very much a collaborative approach. We do seek to address local priorities, and you may well find that when you speak to some health innovation networks, they may say, you know, it looks great, but it's perhaps not a priority in our footprint. But we do know, for instance, our neighbouring health innovation network is very interested in this sort of innovation. So you may find sometimes that we will refer you to one of the other 14, just because we might feel that you might get better support from them. We are really interested in not only spreading proven innovations, but we're also interested in helping to support innovators to decide, is there a need for your innovation? Will it work? Get that clinical feedback, make sure that you really have all the knowledge and feedback you need around patient safety, work with patients, work with carers, really try and get that feedback that helps to inform the development of your product. Next slide. And then nationally, as I said, we try and work really closely together, and we create a network of networks. We do have a small central team. It's not the Health Innovation Network central team really is there to do with aiding communication and sharing across our wider footprint. But it is really important that if we spot something amazing working in Liverpool, that everyone across the country is able to learn and understand that this could be something really interesting to adopt in Cornwall or London. The fact that we work as a network also allows us to import and export innovations across the local areas, and we do maintain a national pipeline of promising innovations that we then can search. So if we are looking for innovations that address a certain need, we can look and see what's being worked at across the whole health innovation network. What that should mean is you don't have to work with every HIN. You can work with 1 or 2 HINs, and then we will then share and collaborate across the wider network. And this means that the resources we have can go further. We can support more innovators because we're not all supporting the same innovators again and again and again. Next slide. So we absolutely work with our patients, and patients are absolutely the core of what we do. We want better outcomes for patients, but we are also, you know, really keen that our NHS regions and systems, and associated to that, the local authorities and the wider geographies around them, also get some benefit from the work we do. But we are hugely invested in supporting innovators. You know, we do feel that part of our key responsibility is to support UK PLC, which means that we're bringing jobs, we're bringing economic growth into the country. So calls such as SBRI are really important to us because it helps us to provide that accelerated support to the most promising innovations. Next slide. Next slide. So our support for industry is very closely balanced and complemented by our offer to health and care. So we tend to work closely with health and care, understand what their priorities are, understand what the problems are, and then we try and match innovations that we think are good. And the key aim is if we can expedite promising innovation adoption, it helps the health and care systems, but it also makes it much easier for industry, because we do recognise that industry has sometimes this massive gap between initial idea and a wider adoption that sometimes unfortunately means that good innovation fails because it's the time to profit is very long. We're trying really hard to reduce that, but because we do appreciate how difficult it can be. Next slide. I won't go through this, the slides will be shared, but it's just to show that the success that the Health Innovation Network has had, say, last year, we've managed to provide a huge amount of support. We've created, you know, opportunities for innovations to be adopted. Currently within our national pipeline, we have over 1,500 innovations that we're actively supporting as a network. Next slide. So how can we help you? Next slide. So we tend to work with innovators. You know, the main work we do is really trying to support innovations from initial idea proposition right through to deployment. And we focus a lot of that work around what we talk about as the value proposition. So we're really keen to help innovators really understand why would health and care buy your innovation, what value is attached to it, look at that value proposition, and then help to develop and prove what that value proposition. We speak to lots of innovators that say, we know this will save time, we know this will improve outcomes, we know that this will save money. But actually, sometimes you need to be able to put an innovation into a real world scenario to be able to prove that it can truly bring those benefits. So that's very much some of the work we do. And then finally, you know, we know that implementation and deployment is tricky and it's difficult. So really helping to drive that deployment of proven innovations. Next slide. We have 4 key roles: identifying need and communicating regional priorities. So we work with our health systems to try and understand and define the need. And I think this is a real gift to innovators, because if we can say the actual problem here is, it's not that we, you know, our heart failure pathway is failing, or our women's health services are struggling with waiting lists. It's really trying to define what that problem is to help innovators then create a solution that truly matches that. We do a lot of work signposting and supporting innovators, and a lot of the questions I saw place in the beginning, you know, speak to your Health Innovation Network team. They will help you to really unpick a little bit about whether your innovation has an opportunity within health and care, whether it addresses priorities. And if not, it might help you to redesign your innovation to make it match more closely. We do offer validation in real world settings. So we work with health and care systems and innovators to test innovations in a real world setting to see how difficult is it to implement? Do staff like it? Do patients find it acceptable? Does it create the time savings, the cost savings, the improvements that we're looking for? And we publish and share that data independently. And then finally, for the right innovations, we look to support adoption and spread of those innovations across our system. Next slide. I won't go into this too much, but it just helps to position where the SBRI sits. There's lots of funding themes that we do support, but we very much see the SBRI right there in the heart of what we do. It's in that proof of concept, real world testing area, allowing innovations to be ready for wider adoption and spread. Next slide. Real world evaluation, it's all about collecting evidence of positive impact along with clear guidance on implementation. So what we would like to do is be able to say to our health systems, we've tested this, we can see that it's beneficial, and this is what we think you need to do in order to adopt it effectively. Next slide. We're running short of time, so I'll click through that one, please. Next slide. We do work quite closely with the NHS Innovation Service. Some of you may also know this, but it's a really good portal if you're looking to get support beyond the Health Innovation Network. Partners include organisations such as NHS Supply Chain, NICE, MHRA. Also, if you're looking to access the health innovation organisations in Scotland, Ireland or Wales, it's a really good route through. There's a nice needs assessment service, which would really quite beneficial to a lot of innovators. Next slide. Every health innovation network has the same company engagement form. Most of them will have it as an online link on our websites. Mine certainly does. And it's the same form that you fill out once. Once you filled it out for one health innovation network, you can use the same form to engage with other health innovation networks. We're trying to reduce the number of times you have to say the same thing to the same people. I would encourage people to fill them out. They are quite long. They do need a little bit of time, but they massively help us to understand how we can best support you. Next slide. So relating to this call and other SBRI calls, the sort of support that you can get from the Health Innovation Network would include connections and brokering. So if you're looking at, if you're a company or an organisation with an innovation and you're looking to find partners within healthcare, we may be able to help you with that. Similarly, if you're working in healthcare and you perhaps are looking for some evaluation support or perhaps an industry partner, you know, we're really interested in making those connections. We are here to help you with your bid. Our teams are very used to supporting reviewing of bid paperwork. There's always a question about, you know, how are you going to work with your health innovation network on the form? Please do contact us, you know, and in my experience, those bids that have spoken and given plenty of time for us to give some feedback on your bid do stand a better chance of hitting the target and getting it right. Our evaluation teams are extremely experienced in this space, and if you would like some advice or support about scoping out your evaluation, agreeing some logic modelling, you know, a lot of the HINs will offer that service. And also advice on, you know, project management, you know, how do you structure your project, particularly for innovators that are perhaps less experienced in that space. Some HINs may also offer you the opportunity to add them into a bid as a partner, but not all, and that's very much done outside of the scope of our core commission. But by all means, you may find that some HINs are willing to support you in that way. Next slide. So next steps, if you would like to speak to any of the health innovation networks, either find your local HIN, and we're always very happy if you're based on our region, please do feel free to contact us. However, if you are working with a clinical system or a particular provider within a certain footprint, I would suggest you connect with a HIN that's local to them, because that would help us to really work most effectively with you. I'd rather work with an innovator who's based in London that's working in Bristol than have that, you know, the another HIN trying to engage with our local systems, but not really understand the system as well. But please, you know, reach out to us, contact our commercial teams across our websites. There will be some information shared in the slides about how to contact us, but we're really, you know, happy to have conversations with anyone that would think that we can be helpful. And I think the next slide is my last slide, which is just some contact details.
Perfect. Thank you so much, Sam. Just a really quick question. Is it too late to connect with a HIN for the applicants who...
Absolutely. You know, I'm getting daily contact at the moment, so more than happy to speak to anyone. Do try not to contact us 2 days before submission date though, because we may not be able to help you. Just give us as much time as you can.
Thank you so much. I will free you up because I know you need to run, but thank you for being with us and your support. And Alex's presentation will be shared. So please feel free to reach out through the links that Alex highlighted in her presentation. So we will now move on to my colleague Mary, who will tell you a little bit about the assessment process, and then we'll move on to the second Q&A session. Just to let you know, I know that we have a lot of questions in the Q&A box. We will try to get to all of as many of them as possible. I will prioritize the questions around clinical eligibility next, but do not fret, because we will have a separate Q&A session where you can come and ask us about anything to do with the application, and the details of that will follow. They're already on our website, but I'll tell you a little bit more about them when we finish. So over to you, Mary, for now.
Thanks for the introduction, Kasia. Yes, I'm Mary Walker, and I'm going to talk to you about the assessment process and how to apply. Next slide, please. So before I go into the nitty-gritty details about the application, I wanted to give you a brief overview of the process. Remember that this competition is for phase 1 funding, so we're referring mostly to the left side of this image. The application is an online form, and it's already available online on the applications portal. It closes on the 28th of August at 1 p.m. After submitting, each application will undergo shortlisting, and this is where your application will be assessed by our reviewers that include experts with challenge-specific knowledge, but also those with commercial expertise. If your project is shortlisted, applicants will be invited to submit a short video pitch, and this will supplement your application during any further meetings. We're aiming to announce successful applicants soon after this, and we'll carry out due diligence and the contracting process for projects. And we aim to start all projects in January 2025. Now, these projects should have a duration of up to 6 months and request up to £100,000. Now, after phase 1 has ended, and if the project is successful, you'll be invited to submit a phase 2 application. And this is more comprehensive than the phase 1 application and goes through peer review. Next slide, please. This slide gives you an overview of the key dates for this competition. If you need ethical approval for anything, it's advisable that you begin this before your project starts, as you won't have enough time otherwise. Next slide, please. So now we move on to the SBRI Healthcare website. And from here, you can find all the information and documents you need to read when you're putting your proposal together. And I strongly recommend that you read everything, because a lot of your questions will be answered there. You can click on competitions. Everything I'm saying is circled in red there. You can click on competitions and then click on open competitions. And for the competition you're applying for, you can click on the read more button. Next slide, please. This page opens up, and the key dates are along the left, and the button to get to the application portal is on the top right. And if you scroll to the very bottom of the page, that's where all the supporting documents live. So please read these as they are useful. An example is our development agreement, which is effectively the contract. These terms are non-negotiable, so please do have a read and make sure you're happy with it before putting in all the effort of applying. Next slide, please. So now about the application itself. All of this information can be found in the invitation to tender document. And the applications will be based on 8 criteria, and they all have weightings attached to them. So I'm not going to read through this entirely, but it includes things like evidence of your innovation itself, project plans, competitive advantage, IP management, commercialization, etc. Again, the invitation to tender document has all this information in it. So once you're done reading and you want to apply, you need to navigate the SBRI healthcare website and submit your application through the application portal. Next slide, please. So accessing the application portal brings you to this page, which is the research management system, and we call it the RMS. If you've applied for SBRI healthcare funding before and you've already got an account, then you can just simply log in. If you don't have an account, you'll need to register for one. Please note that these accounts need to be manually approved by our team. So I'd strongly advise that you do this as soon as possible, just in case there are any issues. Next slide, please. Once you're logged in, update your personal details using the Manage My Details tab on the left. If you've applied before, then it's worth checking if these details are still correct. This particular information is used to populate part of the application, so it's important to keep it up to date. And once you've updated your details, you can start a new grant application by clicking the My Applications, again on the left tab. Next slide, please. So we currently have multiple competitions open, so I'd strongly advise you apply for the right one. The one we're talking about today is the SBRI Competition 25, Phase 1, Women's Health. And once you found it, click on Apply. Next slide, please. Then it brings you to this page, and you'll notice the little question marks on the left. These are prompts and suggestions for you to consider. The information should be used together with the information in the Guidance for Applications document on the SBRI healthcare website. And you don't need to complete the application all in one go. You can save the changes you've made by clicking the appropriate button on the top right corner. Next slide, please. So as you proceed through the form, you'll come across this section about your team members. And this includes the team members in your organization, your clinical partners, subcontractors, advisors, etc. So the team members are the individuals based in the same organization as the lead applicant or organization. And if you have a collaborator, you should make use of the clinical partner, subcontractor, or advisor sections first. But note that before you can add them to your project proposal, they must have an RMS account first. So I'd encourage all your team members to sign up onto the RMS also. Next slide, please. And so once you've added them to the application, they need to navigate to the My Co-Applications tab on the left side of their account, which brings them to this screen. They need to confirm their participation in the project, and you can only submit the application once everyone has confirmed their participation. So as a lead applicant, the portal allows you to track which of your co-applicants have confirmed their participation in the application summary page. And so we hope this is helpful. I'd like to add that this can be the most tedious part of the application to complete, especially if you have lots of team members and lots of collaborators. So I'd strongly suggest that you prompt your partners and collaborators to register as soon as possible to avoid any issues. I also want to flag that if you miss the application deadline because of this, we will not consider taking your application forward. And once everyone's added and you're happy with the details of your application, you can go ahead and submit it. And that's all from me. And if you have any questions, please feel free to ask them in the Q&A box or feel free to email us. And you can go on to the next slide, please. Great. I'll pass on to Kasia.
Thank you. Thank you so much, Mary. I hope some of your questions were answered during this presentation. I just wanted to bring Sam back if possible. There'll be a number of, we've still got a number of clinical eligibility questions. And also if I can ask Charmaine to come forward as well in case we manage to get through any of the kind of more technical questions around the application. My colleagues will be working in the background trying to answer some of your questions that we can type the answers to. But I just wanted to start off with a really important question that featured in the chat. There is no mention of trans, non-binary, and gender diverse women. Can applications specifically support these service users? And I just wanted to say, sorry if this was not clear enough in the challenge brief, but absolutely yes. Sam, I'll hand over to you.
No, absolutely. I should have mentioned that before. Absolutely, yes. We want this to be as inclusive as possible, though. So for people who are born biologically female and transition to male, and people who identify as female. So yes, absolutely, we need to be as inclusive as we can.
Thank you so much. So I just wanted to address that as early as I could. And then I think there was a question around the digital exclusion tool, Sam. Where can it be found? And
yep. I can certainly give a copy to people. I mean, when slides are handed out, if you're just linking with me, I'll send it through. Yeah, we can do that. And same with the healthy equity framework as well. Absolutely, we can send those out to people.
Yeah, so. Perfect. Yeah, we'll include the appropriate links in the slides then for all of you to see. Thank you. Okay, let me just get myself together with this. So there is a question around a solution which addresses some of the issues of women's health at scale, especially around personalized education. But the innovation would be around adapting what they already have, an existing technology they already have to address health inequalities. Can this adoption of the technology to improve accessibility qualify for the call? Sam, what do you think?
Yeah, I mean, my view would be if we are increasing access and increasing, if we think about that 6-point plan that came through from the national strategy around increasing education and awareness, then actually it has, yes, I can't see why that would be a barrier to applying. Yeah, because ultimately, it's created, it's fitting with those kind of core underpinning principles of the women's strategy, isn't it? Which is to, inform and raise awareness and then make sure that we are kind of increasing access to women. So yeah.
I suppose just to add to what Sam is talking about is also please consider whether the same type of innovation or technology works for the minorities or those who suffer from health inequalities, because sometimes the same type of technology may not work quite as well. So there will be a piece in the application process around the fit and how well you've co-designed the solution with the specific groups that you're targeting, so that there'll be we're focusing on it very strongly in this call. There is another question around breast cancer prognosis. This is an AI tool, so this innovator is asking around so that they're developing clear prognostic insights that can help improve breast cancer treatment outcomes and help improve women's health. Their tool is more affordable than the current market tool, and it adds higher prediction accuracy and easier access. And they assume that it will help low-income populations. Would they fit under one of the 3 categories? Do you think that would fit under the long-term health, Sam?
Yeah, I would think so. Yes, I mean, and again, I think if you're demonstrating that you are recognizing that there are inequalities within inequalities. So we know there are certain subsets of women who will not be getting their breast screens done. Then yes, I think it's about how you articulate that argument. So we might find, for example, that we might have particular populations where you've got a higher density of women from Black and ethnic minority backgrounds who might be getting their screens too late, because actually the NHS at the moment is saying it's 50+. We know that, you know, that we can have, we also might have populations where we've got a higher trans population, and actually, but we still need to be thinking about breast screening. So there are different ways that you can cut the cake, aren't there, really? But I think the important thing is that women get a quicker diagnostics and more thorough diagnostics, and that we are recognizing that inequality. So just really think about that intersectionality would be my advice.
Thank you very much. What about an IBD or method which addresses health equity within the female population? For example, a C-section versus natural birth, at the different risks postpartum. Do you think that would be included, Sam?
So that would be an advice tool, would it, for women? Is that what they're proposing? What was the?
Yes. So it's a method address health equity. Yeah, I'm not entirely sure actually what type of innovation it is.
Because I thought you said intrauterine device. I was a bit confused. Do you mean an intrauterine device postpartum, or?
Yes, you're absolutely right. I'm not entirely sure.
Yeah.
So, but I think again, I would say that Sam mentioned the inequalities in maternity care and around pregnancies, and I think it's really important to address those and look at the innovations from this perspective. So I think if there's a very clear case for developing something that will really support either clinicians supporting mothers that face health inequalities, or for mothers to learn, I would say it would be eligible.
And I think, yeah, I think there's something in here about shared decision making. I think the more that we, you know, that you can demonstrate that your technology encourages and empowers. So that's about, you know, that shared decision making with kind of, and I think areas as well, like preconception care as well, I think are really important. So we need to be thinking about actually how do we optimize mum's health before mum becomes pregnant, you know, because, you know, that's kind of a key area as well. But I think, yeah, I think certainly areas around pessary feeding larks, hugely expensive. And again, you know, a large significant part of our wait list, because it's a very specialist kind of procedure. So I think, you know, thinking about what are on those wait lists and how could they be better, some of those needs be better met through using technology or innovation.
Great, thank you. And there is a question around the end buyer. So does the innovation have to be sold to the NHS, or is it okay if the final buyers are women's employers?
Good question. I would think, well, I think if we use that principle of an integrated care system, then actually, you know, the NHS is just one part of that. That's your healthcare. But we're talking more broadly about keeping people well. And the workplace was absolutely an area that was, again, in that 6-point transformational plan, that actually how can we be working alongside workplaces to ensure that we keep women in work, that actually that employers are aware of female health difficulties and make necessary adjustments. So I think it's an education piece on both sides, really, isn't it? And we know that kind of, you know, having work, being economically stable improves your health. So I think, again, how you articulate the argument is what I'd be looking at. So if you can demonstrate that by doing X, Y happens, or there's a correlation, then that's how I'd be approaching it. And so yes, and the other thing to recognise, of course, is the NHS in itself is a huge workforce employer. So, you know, it employs over 1 million people. So, you know, by definition, you can
absolutely.
look at NHS workforce.
And there's a number of examples in the challenge brief as well that mentions schools and also employers. So yeah, please have a look at those examples and be creative about who your buyer is, and you know where you want to reach. But please don't forget that the NHS or clinicians still may need to be brought on board with developing your innovation. They might need to obviously depending on what it is that the innovation is trying to achieve, but it might be beneficial to have clinicians on board with the development. And then slightly the other side of the coin as well, are medical devices that aim to get to market without using the NHS, but rather working with private clinical partners eligible for the SBRI call. I can start with that. And
Yeah.
Sam, if you have anything to add, please feel free. So the primary aim of the SBRI call is to improve care for patients in the NHS and to not increase health inequalities. So I would say that no, if your only goal is to sell in the private sector, I would say that that innovation would not be eligible.
Yeah, no, I agree. I think that's right. Because yes, exactly. You are kind of just driving inequalities further, aren't you? And I guess we come back to that whole kind of equity argument as well. You know, we're just creating a greater divide. But that's not to say that we can't use some of the learning that's been gained through working with private sector partners to translate into NHS settings.
Yeah, that's a question that we had in the past. Just to add to it, because I think there was a question around there was a follow-up question around that that I saw in the Q&A box. You will be perhaps more scrutinized on the need for funding, especially if you are an established company. So there will be questions around, you know, whether you need public funding to develop this, or whether you could support yourself to develop the tool further into aiming for the use in the NHS. It's not to say that obviously, you know, as we discussed, it is eligible and you can apply, but just please be aware that there will be questioning around that, seeing that this is we're talking about public money that comes from NHS England, so there's all those considerations to take into account.
Yeah.
A few more questions. I'll try to cover as many as we can. Will the UTI and viral infection prevention care be considered eligible for this call?
I would imagine so. I mean, it comes under gynecological, doesn't it? And we know that there are lots of hospital admissions as a result of UTIs, particularly in older women. And particularly we're starting to kind of get sometimes kind of deliriums that are kind of presenting because kind of UTIs have kind of progressed quite quickly. So actually ultimately that's about, you know, it's about saving admissions really, isn't it?
Yeah, absolutely. I think, yeah, just to answer maybe a bulk of eligibility questions, I think for sure if there's something that addresses health inequalities, again, because you can count how many times I say this today. But if the innovation really is working with women who have been marginalized for whatever reason, women and people who have been marginalized for whatever reason, those innovations will be prioritized. And anything else that you're developing that is not explicitly mentioned in the brief, I would say really think about the market and what else is out there. Sam has already alluded to this before. You know, really think about your competition and the need, the specific need for your solution. We will be questioning this during the assessment process. And you know, what is your unique selling point? How do you differ from what is already out there? So I'd say those are the considerations. I think nothing is explicitly excluded, but there are things in the challenge brief that are highlighted because those are the most important priorities to focus on. Yeah, we couldn't include everything in it, but please consider your market and consider who will be using your innovation and who you are working with to develop it. So I'll try to move on to a few. We don't have a lot of time left. I'm just trying to see what is the most important one to cover. I suppose I wanted to cover this. Does there need to be a commercial end product would the development of information resources available free of charge to patients, for example, be acceptable? What's your view on this, Sam? What's your advice?
Sorry, can you repeat the question again? My sound cut out.
Yes,
Sorry.
yeah, sorry. Does there need to be a commercial end product? Would the development of information resources available free of charge for patients be acceptable?
Good question. I suppose it depends on the who's kind of, I guess we've talked before about sustainability, haven't we? And spread.
Yeah.
So how is something going to be, if there's no commercial aspect to it whatsoever, how are you going to give that away for free? How's that going to work? Again, I guess it depends on kind of your business model, really.
Yeah.
Who's developing the innovation, really.
Yeah.
Great if you want to develop something for nothing and not charge for it, but I don't know how that would, I don't know how that would actually grow, the economy. So I guess it's trying to balance quite a few different factors, really.
Yeah, absolutely. And how would it be evaluated? How would the whether it works or not and how well it works be evaluated? So there might be a case for perhaps partnering up with someone who maybe is developing a separate part, but you could team up and maybe provide it as an addition and work together to deliver something that can have that sustainability. I think we might have to close because we are at the time. I realize that there's a number of questions that we haven't had time to get to. If we move on to the next slide, please, Tommy. So we will have, as I mentioned before, we will have a Q&A session on the 8th of August. You can register using the Eventbrite link, and there you'll be able to come and ask your questions, face to face to us. We'll look at the questions and see if it makes sense to have some additional time and maybe some additional people join the Q&A session if it will be possible. I can't promise anything, but we are also you also have our contact details, which are on the last slide, and you can get in touch with the SBRI team through there. Thank you so much. So please do reach out if you need any help or if there are any questions that have not been answered. I would say probably the Q&A session is the best way, and we can address multiple questions at the same time. So really sorry if we didn't manage to get to your question, but we will one way or another get there. Thank you so much for being with us today. Thank you for staying for the whole day with us, Sam. Really appreciate your insights, and we look forward to receiving your applications.
Yeah, good luck, everybody.